Now I'll discuss about inflammatory bowel disease. It is a condition characterized by widespread inflammatory damage to different parts of small and large intestine. The pattern of inflammation and subsequent clinical features lead to two distinct clinical entities. So first is Crohn's disease. What is Crohn's disease? This is characterized by relapsing and remitting segmental patchy inflammation of intestine. Relapsing and remitting segmental or patchy inflammation. Sites are terminal ileum and proximal ascending colon. Terminal ileum and proximal ascending colon. Terminal ileum ileitis and large gut colitis. However, involvement of sigmoid colon and rectum is extremely rare, and this variety is usually associated with perianal manifestation. What will be the clinical manifestation? In Crohn's disease, it may be chronic or rapid or acute. They may come back after a quiescent stage when the disease flares up. In Crohn's disease, there is ileocolitis. Chronic inflammation and intestinal obstruction is there, and fistulization may occur. That is intestinal fistulization. And there is also perianal disease. So this is in Crohn's disease. And few other extraintestinal features are present. Now, what are the clinical features of ileocolitis? Due to chronic inflammation, there is pain abdomen, often in right iliac fossa. There may be diarrhea, which is usually watery, rarely bloody, fever, loss, appetite, and weight loss. Right iliac fossa tenderness. Mass may be present due to matted intestine, lymph nodes, and mesentery, and features of malabsorption syndrome. There is problem in absorption of food. Due to intestinal obstruction, other features are abdominal pain, bloating, constipation, distension, vomiting, flatus. And lastly, due to fistulization, there is enterocolic fistula, malabsorption, entrovesical fistula, that is feculent urine, enterovaginal fistula, that is feculent parvaginal discharge, and enteromesenteric fistula, intra-abdominal abscess. So these are the clinical features of Crohn's disease. Few extraintestinal manifestations like stomatitis, inflammation in eye, mouth ulcer, liver and bile duct inflammation, skin ulcers and sores, stomach, vomiting, and few intestinal manifestations: diarrhea, abdominal pain, cramping, ulcer in digestive tract, rectal bleeding. Other as joint pain and swelling. Now, what investigation should do? First is blood test, hemoglobin, total count, differential count, ESR. So all TC, DC, CRP and ESR will increase as there is inflammation or intra-abdominal infection. So all things are increased. Hemoglobin is decreased due to chronic inflammation, iron deficiency and vitamin B12 deficiency. Renal function, sodium, potassium, urea, creatine is checked. If malabsorption is suspected, then albumin, serum calcium, vitamin B12, vitamin D, iron studies are done. Stool is looked for any ova, parasites or cyst. Fecal calprotectin level is high. Colonoscopy shows mucosal inflammation or ulceration with skip area. So that is important in Crohn's disease. There is presence of skip area. This actually differentiates from ulcerative colitis. And on colonoscopy shows mucosal inflammation or ulceration with skip areas. Colonoscopy biopsy confirms the diagnosis, and this confirms diagnosis. Barium follow-through shows any filling defect, anatomical deformity. It is done particularly when small bowel involvement is suspected, and colonoscopy is inconclusive. Capsule endoscopy or enteroscopy to visualize small gut, and CT scan, contrast enhanced CT scan of abdomen to visualize the internal structure of any obvious anatomical deviation. What are the treatment of Crohn's disease? So first is supportive treatment. If severe diarrhea or volume depletion occurs, then admit the patient in hospital and IV fluid is given in severe diarrhea. Nil per mouth till clinically improved to give bowel rest. Circulation is maintained by IV fluid or intravenous fluid in severe diarrhea. Bolus maintenance depending on the clinical scenario. Catheterization is done to monitor urine output if required. Drugs like analgesic, antispasmodic, antidiarrheal, analgesic, antispasmodic like drotaverine and dicyclomine, Antidiarrheal like loperamide may cause paralytic ileus and antibiotics often give empirical. Now what are the specific treatment? Specific treatment is like, first is aminosalicylase to maintain remission. No longer the first line drug can be used as adjunctive steroid drugs, that is mesalamine, olsalazine and balsalazine. No longer the first line drug can be used as adjunctive steroid. The second is corticosteroid. Drug of choice is most Crohn's disease patients to achieve remission. Systemic corticosteroids, prednisolone, methylprednisolone, and lastly immunomodulator used in moderate to severe disease to induce or to maintain remission. Non-biologic like azathioprine, methotrexate, cyclosporine. Biological agents like infliximab or natalizumab given. And surgery in medically refractory cases for complications, ilectomy, that is, or ileocolectomy, that is excision of ileum or portion of ileum and colon is done, mainly in cases of the complications like intestinal obstruction. So this is the basic thing about Crohn's disease. Now I will discuss about ulcerative colitis. It is characterized by relapsing and remitting inflammation of the colon, which is continuous in nature. Common sites are sigmoid colon plus rectum, proctosigmoiditis, and left side of the colon, left-sided colitis, and pancolitis. So these are all the types: sigmoid colon plus rectum, proctosigmoiditis, left-sided colon, left-side colitis, and pancolitis. Clinical features: manifestation can be chronic or rapid or acute on chronic. They may come back after a quiescent stage when the disease flares up. Mechanism of the clinical manifestation: due to chronic inflammation, due to toxic megacolon, and few of the extraintestinal manifestations. Clinical features due to chronic inflammations are bloody or non-bloody diarrhea, hemodynamic instability plus minus pallor, abdominal pain like lower upper quadrant and lower quadrant pain, that is continuous or spasmodic, and constitutional features like fever, weight loss, loss of appetite, etc. Now, what are the clinical features due to toxic megacolon? A potentially lethal condition. It is a non-obstructive colonic dilatation larger than 6 cm with signs of systemic toxicity. And toxic megacolon actually is high form of paralytic ileus and causes perforation, hemorrhage, and bacterial translocation. Abdominal pain, plus minus distension, abdominal tenderness, sluggish bowel sound, and toxicity feature, fever, tachycardia, flushing are the features of ulcerative colitis. And it can be differentiated into 3 types, that is mild, moderate, and severe, based on few criteria, that is number of stools per day, weight loss, pulse, fever, hematocrit, ESR, and albumin. And few of the extraintestinal manifestations are also there, like ocular uveitis plus episcleritis, lungs involvement, interstitial lung disease, heart involvement, non-infective endocarditis, abdomen involvement, gallstone may be there, and it is more common in Crohn's disease actually, gallstone, liver, primary sclerosing cholangitis, ulcerative colitis, kidney nephrolithiasis, that is more common in Crohn's disease, skin there may be erythema nodosa or pyoderma gangrenosum, and in joints there may be seronegative spondyloarthropathy or polyarthritis. What will be the investigations? Blood test is done in case inflammatory or intra-abdominal infection. So ESR, CRP all will increase. Hemoglobin will decrease due to blood loss. TC/DC will increase. Renal function, sodium, potassium, urea, creatinine to look for any dehydration, serum albumin level. As significant in case of significant inflammation, albumin is first marker to decrease. Stool, look for ovum, parasites, cyst, gram stain, culture insensitivity, fetal calprotectin high. Straight X-ray of the abdomen to look for toxic megacolon, diagnosed when colonic diameter is more than 6 cm. Sigmoidoscopy or colonoscopy will visualize inflamed, ulcerated mucosa, and biopsy confirms the diagnosis. CT scan of abdomen to look for any structural abnormality. Now, treatment of the ulcerative colitis. First is supportive treatment. More than equal to 1 relevant. If patient is very sick, admit in hospital. If very sick, then nil per mouth for giving bowel rest. Circulation, IV fluid, bolus plus minus maintenance fluid depending on volume status, and blood transfusion if required. And drugs are given: antidiarrheal, loperamide with caution, best avoided during active flare-up. Analgesic, antispasmodic, trotavirin, antibiotics like, particularly if toxic megacolon is suspected. And The antibiotics used are cefuroxime, piperazine or piperazine tazobactam plus metronidazole. What are the emergency treatment for toxic megacolon? Nil per mouth, IV antibiotic, IV hydrocortisone, colonic decompression by flatus tube or colonoscopic tube. Surgery is partial colectomy. Now few specific treatment. First is amino salicylic acid compound. To achieve and to maintain remission, usually first line therapy in mild disease is mesalamine, osalazine, valsalazine, and corticosteroids to achieve remission in moderate or to severe ulcerative colitis, that is prednisolone, methylprednisolone, parenteral or IV, hydrocortisone, enema and foam, and lastly immunomodulator to achieve and to maintain remission. Moderate to severe ulcerative colitis, in cases of the moderate and severe ulcerative colitis, non-biologics like cyclosporine and biological agents like infliximab. Surgery is done in medically refractory cases or for complications, partial hemicolectomy. So partial hemicolectomy is done in cases of ulcerative colitis. So what are the basic difference between Crohn's and ulcerative colitis? Pattern of inflammation in case of Crohn's disease is patchy, but in ulcerative colitis it is continuous. Site is ileocolitis, ileitis and colitis in Crohn's disease, but in ulcerative colitis it is proctosigmoiditis, left-sided colitis and pancolitis. Diarrhea is not bloody in Crohn's disease, but in ulcerative colitis it may be bloody. And malabsorption, fistulization, that is fistula formation, perianal disease, intestinal obstruction, cholelithiasis, that is stone formation, nephrolithiasis, kidney stone formation, that are mostly in Crohn's disease. Malabsorption, fistulization, perianal disease, intestinal obstruction, cholelithiasis and nephrolithiasis. And toxic megacolon and primary sclerosing cholangitis, these two things are more common in ulcerative colitis. So these are basic differences between Crohn's disease and ulcerative colitis. Hope you have enjoyed this video of inflammatory bowel disease. Please like this video and share and subscribe my channel Prefrontal Cortex. Thank you.